be discussed by Dr. Bharath MD. Is currently the medical director and consultant endocrinologist, Alka Center for Hormonal Health, Anna Nagar, Chennai. He is undergraduate from Tirunelveli Medical College. It is General Medicine MD in Lucknow. And Amrita Institute of Medical Sciences, it is DNB. He is a recipient of Torrent Young Scholar Award and A.V. Gandhi Memorial Award for Best Research Work in Endocrinology. Series of Industrial Pediatric and Reproductive Endocrinology. Dr. Bharath.
Thank you, sir, for the introduction. And to thank Kumaravel sir for inviting me again for the receptor for several years in continuity. So the topic for me is a very focused one. A 7-year-old boy with a small penis, and what would be our approach? So since morning you would have listened to so many talks on so many guidelines about various diseases, controversies on the guidelines on the controversies, and so many other things. So the small penis, there is no, I'm not going to talk about any guidelines because actually there is no guidelines regarding how to approach these things. And there is not much of controversy also what to be done, which I will discuss in the end. So generally in the conferences or in the talks, we start from simple things and then we talk about complex things. But I am going to do the reverse. I am going to talk the complex thing first, so that the rest of the thing is going to be simple for me towards the end. So the complex thing is understanding how the sexual differentiation happens in the fetus. And we all know there is usually a bipotential gonad in the fetus up to 6 weeks. And from 6 weeks of the fetal the differentiation starts depending on what chromosomes are there, what are the transcription factors which are governed by the chromosomes, and what about the gonadotropins, the testosterone, dihydrotestosterone, AMH, and the inhibin B. So it's a complex interplay whether the bipotential gonad is going to develop into a male gonad or into a fully formed female gonad or in between. It depends on all the factors, the chromosomes, the transcription factors, the hormone. So it's not one thing which decides the ultimate development of the bipotential gonad. So the same thing, the urethral groove, the genital tubercle, the urethral fold, and labioscrotal swellings, all those things, they transform into clitoris, labia, and vaginal orifice in a female, whereas that same thing transforms into glans, penis, and scrotum in a male. And again, this is the same thing, like it's just a depiction of what weeks it starts. So what we should understand is that at around 12 weeks, 12 to 14 weeks, as you can see, the male and female gonad development completes, and beyond 14 weeks you get only the enlargement of the penis, the lengthening of the penis. So any insult which happens before 14 weeks causes a kind of a disorder of sexual differentiation where you will have a undifferentiated kind of a gonad. So after 14 weeks, if any insult happens, that only determines the length of the penis, and it is not going to affect the other labioscrotal fold or other the urogenital fold and all. So this thing we should keep in mind. And when we think about the hormonal interplay, we know that the GnRH is getting secreted from the hypothalamus. It stimulates the pituitary to produce two hormones, FSH and LH. They act in testes, and FSH stimulates the Sertoli cell production, and it stimulates inhibin B, and the inhibin B in turn controls the FSH secretion, whereas the Leydig cells are stimulated by the LH and they produce the testosterone, and testosterone in turn gets converted to estradiol by aromatase, and that testosterone and aromatase in turn tries to control the LH. And in the periphery, testosterone, or in the gonad, the testosterone gets converted to dihydrotestosterone by the enzyme called 5-alpha reductase. So this is in nutshell what happens and how the testes function under the control of the pituitary and the hypothalamus. And again, this is how these hormones get secreted is one thing which we should understand. During the fetal life, during the first trimester till the end of pregnancy, you see that there is a fluctuation, there is a higher increase in the FSH, LH, testo, AMH, inhibin B, everything increase. And there is a dip in all the hormones immediately after delivery. Then again, you call this period as a mini puberty, which we will discuss a little later. This is a time when again there is a second peak of FSH, LH and testo happening in a male. So this mini puberty lasts till 6 months at the maximum. It usually ends by 4 months in majority of the children, and after mini puberty there is a prolonged quiescent phase in the childhood, and then the growth of the gonadal axis gets restarted from around the pre-pubertal age. So all the hormones will be very low at this point of time, except the AMH and inhibin B. So coming to the topic, that is small penis. This is a normative data of stretched penile length in boys across childhood and adolescence in different ethnic backgrounds. So as you can see that they have charted all the penile length of boys till adolescence. For US, if you can see, they have got a very good data till 18 years of age, and some of the countries have a good data till 18 years of age. But unfortunately, in India, the nomogram comes to around 10 years of age. We have only few data on extending to after the adolescence and what happens to the penile length after adolescence. So really, we need to have a good normative data to say what happens to these kids. But one message which we should be conveying to most of the kids who come, where parents bring the kids for having a small penile size, we should always try to make them understand that sometimes we may not be well endowed. As ethnicity, you can see that the US data is much robust when compared to the Indian data, but definitely China is behind us. So you can see that the Chinese population, the China is almost in the bottom of this curve. This is the curve of China. So definitely some of the ethnic groups, they are not having the good data. They don't have a good improvement in the penile length also. So the first reassurance will be, it is not that it is not a one size fits all. So that is very true for a small penis, for a patient who comes to us with a small penis. So this will be the first message we may be able to give. But even though we will be maybe mocking China, but China has done a very good thing, because they have got a very good penile growth chart. We don't have that kind of a penile growth chart. They have followed up these kids even till 18 years of age, 20 years, and they have got we know the height and weight growth chart. Like that, China has a penile growth chart. Probably for India, we need to generate, and Dr. Kumaravel has done a lot of work on the adult growth chart, so the childhood growth chart. He can take up this kind of a data and publish a growth chart for this also. So when we take this Chinese growth charts, the penile growth charts, as you can see that between that 5 to 10 years of age, there is only a very small variation in the penile length. Whereas when you come to the adolescent age, there is a wide variation in the penile length. So you can see that the curve widens, the curves widen as they go into the adolescence. Comparatively, when you come to this penile diameter, you can see that the curve doesn't widen in the adolescence. It's almost remaining the same in the childhood as well as in the adolescence. So what the second point which we should understand is that there is a wider variation in the catch-up of the penile growth during puberty. So this is one thing. It is not that if a child at 7 years has a small penis, he is going to end up having the same kind of a problem in the adolescence, because there is a wider variation and they can have a catch-up growth. Just like a small for gestational age child having a catch-up growth at 4 years, 5 years of age, we have a good catch-up growth with regards to the penile length also, and there should always be an optimism when we counsel these kids and the parents who come for a small penile length. So this is the Indian normative data, I would say, and again I would like to show you some of the details. See, as you can see that at 6-7 years, the child we are talking is a 7-year-old boy. So the mean is 6.1 centimeter plus or minus 0.9 centimeter. The minus 2.5 standard deviation. This is the cutoff we take for a micro penis. That is around 3.9 and 3.7 centimeters. So as you can see, here in this area, I'm just taking you through this 0 to 2 years of age. You can see that the mean to 2 standard deviation between 0 to 2 years of age, it is almost 1.5 centimeter difference is there. That means the penile length grows much during this phase, that is between 0 to 2 to 3 years of age. Whereas if you can take from 3 years to around 10 years of age, the variation is not much. It is between 3 to 3.8 centimeters only. That means the growth of penis between this age group, between this 3 to 10 years of age, is not going to be much. Probably a 0.5 centimeter difference or 0.6 centimeter difference physiologically. So no need to worry about these things, because again the variation is going to be wide when they come into the adolescence. And this is again another data which again says that a 7 to 8-year-old boy, the median length is around 6 centimeters. So one data is from all over India. This data is from the West Bengal. So we have isolated areas where we have tried to do a normative data of the stretched penile length, and based on that we can always, when the child comes to us, we can always see the normative data and just compare whether the child is fitting into the criteria of a micro penis or not. So step 1, what I would suggest is, suppose parents bring a child for a small penis at 7 years of age. Look at two things. One is measure the stretched penile length. That is the most important first step which I would do. Measuring the stretched penile length, you can use a simple ruler, a scale can be used, and you have to push the scale towards the mons pubis. It should be up to the bone, and then stretch the penis. Prepucial skin has to be retracted, and the tip of the glans. So from the bone to the tip of the glans, you need to measure. You should not be measuring the foreskin, the prepuce and all. So an accurate measurement of a stretched penile length will be the first step in knowing whether this child really has a small penis or not. Second is, look at the penile shape. It's not only the length, it's the penile shape also, which is very important. So coming to the penile shape first, you can have a webbed penis where there is a congenital deformity. There will be a web hanging at the ventral side of the penis, and there can be a trapped penis. Many times circumcision would have been done, and post circumcision there may be a problem in the prepucial area where the prepuce will completely cover the glans. So you may have a trapped penis secondary to circumcision or a webbed penis. So in this kind of a situation, for a webbed penis you can go for a surgical correction, or for a trapped penis you can go for a topical steroid or a surgical repair if the topical steroid is not working. So when you see the stretched penile length, then you may have two things. One is, it may be normal for the age and ethnicity. So you should have a normative data chart, and you should compare it with the age of the child and the normative data of the Indian child. And most of the times what we end up having is a buried penis because of the obesity. Because nowadays most of the children, we see a rampant childhood obesity, and because of the increase in the suprapubic fat and in the lower abdominal fat, the penis gets really buried into the fat. So if you remove all those fat, if you push the fat aside and check the penile length, it will be definitely more than the or it will be at least falling in the category of a buried penis and not in the micro penis category. So we should always counsel these kids to at least maintain the weight, reduce the abdominal obesity for the buried penis, and no further treatment or no further evaluation would be required for these kids who just come with a small penis and we find it as a buried penis. So rule out a webbed penis, rule out a trapped penis, and rule out a buried penis. If you have ruled out all these things and if the child still fits into the micro penis category, then we should go to the step 2. So this is just a photo of how the webbed penis will look. Then a buried penis which is due to obesity, and a trapped penis that is happening post circumcision. So coming to the micro penis, this is the one thing. After ruling out all these things, micro penis, again, penile length which is smaller than 2.5 standard deviation. I have already mentioned this chart. Actually the standard deviations are given very well in this chart. You can just download it and compare it. If the child is having a small penis, complaining of small penis. So Again, micropenis. Suppose you have ruled out all these things, you come to the conclusion that this child has a micropenis as defined in the normative data, then we should be able to answer four questions. One is whether is it an isolated micropenis, or is it associated with hypospadiasis and undescended testis, or is there any other features of pituitary hormone deficiency, or is it a syndromic form where some of the syndromes may be associated with a micropenis. So we should be able to differentiate these things. Of course, a careful examination will definitely help us to say whether hypospadiasis cryptarchidism is there or not. So the management or the workup becomes entirely different. So you need to think about disorders of sexual differentiation and congenital hypogonadism. If you have a hypospadiasis and undescended testis, as I told you, like 12 weeks before the fetal development, you can have a hypospadiasis. The injury of an insult has happened before 12 weeks of fetal development. You can have undescended testis, hypospadiasis, and other urogenital abnormalities. So the best thing would be a judicious evaluation. Again, here we are going to have a 7-year-old kid. We are not talking about an infant. We are not talking about an adolescent. So how to judiciously evaluate a 7-year-old kid is a great challenge. You know that these are some of the syndromes. You have charge association, Lawrence-Moon-Riddle, Rainbow syndrome, Williams syndrome, so many syndromes, Carpenter syndrome, so many syndromes which are not associated with the classic hypogonadism. They still can have a micropenis. And if you look at the hormonal reasons, you can have a deficiency in the testosterone secretion, or you can have a defect in the testosterone action. You can have a developmental anomaly, or you can have a cloacal extrophy or idiopathic kind of thing. So this is just a broader idea of how to, what are the things you should look for in a micropenis. Again, coming to the management, the same diagram, the same this thing, figure which I mentioned earlier. I told you about this mini puberty time between 0 to 6 months. This is the best time to evaluate a child with a micropenis. Suppose a child is born and then the pediatrician tells that the child has got a micropenis. The first 6 months is the best time for diagnosis as well as the management of micropenis. Because this is the time when you can do FSH, when you can do LH, testo, everything will be in the pubertal category, and you can diagnose the congenital hypogonadism. You can even make a diagnosis of hypergonadotropic and hypogonadotropic hypogonadism. Even trial of HCG therapy, trial of testotherapy were all done, but only in this group of population between 0 to 6 months. And this is the best time, I would say, great window of opportunity which no pediatrician or neonatologist or endocrinologist should miss at this point of view. But many times, sadly, people come at this point of time, like between 3 years to 10 years of age, where all the hormone levels will be less. You have a low FSH, low LH, physiologically low testosterone levels. And many times we end up having reports of low testo FSH LH naturally for a 8-year-old boy, 9-year-old boy with a small penis. And many times they were wrongly judged as having hypogonadism, and the parents also will be very apprehensive, because even if you do the test, FSH, LH, testo, and tell them that these are all physiologically low levels, they won't get convinced. They will at least go to 3 or 4 doctors to ensure. They'll say that, sir, FSH, LH ella kammiya irukku, testosterone la kammiya irukku. 7 years, 8-year-old boy coming to us with the reports. So instead of doing the test and telling them that is normal, don't do those tests. So please don't do any tests, and that will be the carry home message in this talk. So yes, what are the things you can do? You can do a stretch penile length measurement. You can do an anthropometry. Most important is height, weight. Again, the importance of growth hormone, everything has been beautifully discussed by Varun. So you plot the height and weight in the growth charts. You do a thyroid function. You can do an IGF-1 if the growth chart shows the patient is having a consistent short stature. You can do even GH stimulation test at that category to diagnose a growth hormone deficiency if the patient falls in that category. Definite no, don't do FSH, LH, testosterone. Should not be diagnosing hypogonadism, should not be going for a HCG therapy also. Testosterone therapy, again, it can be done only for select group of patients who have to undergo a surgery for a webbed penis or any other kind of deformities. So apart from the anthropometry and the stimulation test, if necessary, you can go for an ultrasound pelvis or MRI to look for any cryptorganism if the testis is not palpable. And karyotype mainly if you suspect any genetic features to suggest a syndrome or genetic features to suggest a hypogonadotrophic hypogonadism. Testosterone injection not very well proven at this childhood. Most of the studies were again done in the infantile period. You can try for 25 milligram 4 doses just as a effect to look for the improvement in the stress penile. But this therapy is given either in the infancy or in the adolescent age group, not in the 7-year-old boy, and there will be definitely a greater discrepancy between the patient satisfaction and the improvement. So growth hormone therapy, again, these are some of the proven therapies where you can use growth hormone. If the really patient has a growth hormone deficiency, definitely usage of growth hormone will improve the penile length. And 5-alpha reductase deficiency can be managed with dihydrotestosterone gel if it is available. It's not available in Indian market. Surgery, as we have already mentioned, in webbed or trapped penis and in a correction surgeries for cryptorchidism, you can go for that. So concluding my talk, a small penis only requires a measurement, monitoring, masterly inactivity, and rarely we use a monthly test for injections.
Thank you, Doctor. You will point out the difference between the various types, the strapped penis, buried, and what's the third one? That is the webbed penis. So these should be ruled out before you definitely go for any treatment. Any questions from the floor?
If there are no questions, we will
We'll go on.
proceed. So I would like Dr. Vadivel Murugan to felicitate Dr. Bharath. Dr. Shanti, please.